want to actually get continuing medical education or continuing pharmacy education credit, there will be information at the end to help with that process. Go to the next slide. So our presenters today, first off, we have Dr. Alan Davis. He's the Regional Medical Director for ProHealth Physicians, part of Optum Care, but he also happens to be one of the board members for Connie, our state's HIE. We also have Dr. Joseph Quaranta, and he is the president of the Community Medical Group in the southern part of the state primarily. He'll talk a little bit more about that, but Joe also has been involved for a number of years as a member and actually co-chair of the Health Information Technology Advisory Committee for the state of Connecticut. Last but not least, we have Jen Searles, and Jen is the executive director for Connie. She's been in that situation or been on that role for since December, and so we're really pleased to have her. She has a prior history of being involved in a number of things, which she'll kind of talk to you a little bit more about. For continuing medical education purposes, none of our presenters have any conflicts to disclose. So before we get to our message from Dr. Vicki Veltri, I would actually like to close our poll here. We didn't have, looked like we have about 88 people that were actually participating at the moment or signed on. And as that, we've got a few seconds more and their poll results will be present. While we're doing that, let me tell you a little bit about the learning objectives for today. We're going to be able to describe the current ways health information exchange is occurring between clinical providers in Connecticut and where it's going in the future. We're going to be able to discuss the effective benefits of an effective HIE to various stakeholders such as patients, providers, and payers, et cetera. And we're going to be able to identify upcoming ways Connie is implementing HIE in Connecticut and discuss how you and your organization can get involved. So if we go to the next slide, and I will share out the poll questions. I think probably people can actually see the poll answers. Poll results, apply, and are and I can't quite see the poll questions myself, but we will get them. I'll share them with you at the end of Vicki's information. So first, we'd like to hear from the Executive Director for the Office of Health Strategy, Vicki Veltri.
Welcome to today's webinar on improving the health of Connecticut citizens, introducing Connie, our official state health information exchange. I'm Vicki Veltri, and I'm the Executive Director of the Connecticut Office of Health Strategy. Our agency is responsible for implementing data-driven strategies that promote equal access to high-quality health care, that control costs, and that ensure better health for the people of Connecticut. One of the ways we do this is through health information technology, or HIT. HIT includes things like securely exchanging clinical data between and among electronic health records so that patient records are available wherever and whenever people seek care. Shared data can reduce redundant tests, can improve diagnostics, can help us better reconcile medications, and hopefully lower healthcare costs for people by reducing unnecessary tests and services, and also ensuring people get access to tests when they need them. We can also use this data to assess the quality of care. Health information exchange can make it easier for providers to access needed healthcare information to care for their patients and improve public health data sharing in the future. Statewide health information exchange is finally becoming a reality for Connecticut. I'd like to congratulate all of those who have collaborated with OHS and worked so hard on this effort. Statewide HIE and participation in the statewide HIE is public policy. It's actually codified in our state statutes. As you may know, hospitals and labs need to begin connecting to and participating in Connie within a year of Connie commencing operations. And healthcare providers within EHR need to begin connecting within 2 years of commencement of Connie's operations. Connie will commence operations shortly. Although the state guided the development of Connie, Connie is a nonprofit, and it's actually governed by its own board of directors. On behalf of OHS, I want to thank you for participating in today's webinar to get to know more about Connie. Take care, everybody, and stay safe.
And there you have it. Vicki Veltri announcing Connie. And one of the things that we are looking at, we did look at the poll questions. We have about 20% of our participants are physicians, about 17% pharmacists, a couple of APRNs and RNs, about 25% are other. And I know there are folks from health information technology groups, and then a number of you didn't answer. Let's go on to the next section. And I'd like to pass it over to Dr. Douglas. Dr. Davis.
Yes, Dr. Douglas couldn't make it today. Well, I'm going to give you a little information about myself and ProHealth Physicians. I joined ProHealth back in 2012 from a solo practice, which I ran for about 5 years. I became tired of being my own IT professional, updating servers, loading patches and updates to my own individual EMR, and ProHealth gave me a perfect opportunity to continuing to practice medicine. ProHealth Physicians is located in every county in Connecticut. We serve both adult and pediatric patients. We take most health insurances. We are a patient-centered medical home, and we use Allscripts as our EHR. Next page. So what is a health information exchange? The verb is the process of sharing health information electronically. The noun of health information exchange is an organization that provides technology and services to allow their stakeholders to share health information securely. So the first question is, why do we need a health information exchange? And this is from the physician's or the clinician's point of view. And the answer is for the Monday morning new patient. This is a very common scenario. It's Monday morning, there's a new patient coming to your practice for the first time. They were discharged from the hospital over the weekend. They wanted to switch to you as their primary care physician. Their data lives in computer systems from multiple practices, hospitals, and testing centers, as well as pharmacies. Their data is not frequently available at the time of the initial office visit. Unfortunately, patients are not always the best historians. We often do not have accurate medicine lists, problem lists, and previous testings. So at the first visit, there is always a scramble to obtain the hospital admission and discharge summaries. If the patient has a history of heart failure, it's important not only to have the most recent echocardiogram, but also previous ones to determine if there has been any significant change. It's also important to be able to compare the new EKGs, chest x-rays, or other imaging studies such as CAT scans with the ones done previously. Labs such as renal function, blood counts, hemoglobin A1Cs, and other crucial tests need to be compared to previous testing. And in the 30 minutes we have for this appointment, time is ticking away. This is the third patient of your morning, and you're already 30 minutes behind. Common scenario. So I'd like to ask the audience this question. Does your organization exchange data electronically through a health information exchange?
We'll give you a few moments there to answer that question and get right back. So for those of you who answered that question, it appears as if I am going to close the poll. We'll get that information in just a moment. But I can tell you what the results are. It appears as if 18% of you actually use your health information exchange for your electronic health record, about 6% through a third-party application. About 25% do not actually use a health information exchange. 13% don't know, and about 40% of you didn't answer this particular question. So let's go to the next one. So there's obviously an opportunity here. Next, we're going to switch over to Dr. Joe Caranta and have him tell you a little bit about himself, his practice, and some of the issues that he hopes to have solved.
Thank you, Dr. Gressa. And first off, good evening, everyone. It's a pleasure to be here with you tonight and also to be along with my esteemed colleagues on the panel. And our organization is a little bit different from ProHealth, maybe the exact opposite end of the spectrum. We are made up of 250 separate practices with over 1,000 different clinicians. And all of our practices are independent and own and operate their own office and therefore their own EHR. So we live in a world where we manage over 30 different EHRs across our entire network. And so we live every day the challenges that I think we all live in, where information is not easily exchanged across our group and across our network. And despite that, we work quite ardently to try to improve quality, to improve communications among our providers. And it really raises the question of how could we do this easier? How could we do this better? And what can help practices like ours and the rest of the delivery system provide better care to our patients and make the process of delivering care easier for our clinicians and our providers. And so I'm really excited here to talk a bit about the health information exchange and what type of benefits it's going to have for some different stakeholders. And I'm going to walk you through just a few group of stakeholders and just highlight what I think some of the benefits are going to be to those groups. And so I'll ask for the next slide, please. I'd like to start off with the benefits to patients, which I think is a key issue to stress here, and that the purpose of anything that we do as healthcare providers, and certainly the purpose of the HIE, is to provide benefits and value to our patients. And I always want to level set in that everything that we do, our patients should be at the center of this. And one of the guiding principles that the Health Information Advisory Council used was to keep our patients as a North Star in all the decisions that we make. And I think we've held true to that. And you'll see as we present tonight and as we develop the HIE further that has been the case in all the work that we have done. And one of the things I want to mention is that I think as a practicing clinician, I can tell you is that most of our patients expect us to be able to exchange and share information. And they expect that their different providers and their doctors and nurse practitioners and pharmacists and hospitals to be able to share information. And I think they're disappointed that we haven't been able to do that already. And so I think from the very start, this is something that patients expect us to be able to do and want us to do. And they want their doctors to be able to communicate, and the test that was done in one doctor's office yesterday to be available to their other physician when they go for their visit the next day. And so I think patients are going to be very supportive and very enthusiastic about this and helping to consolidate and coordinate their care. And clearly, if we can do that better, if we can communicate better and we can share information better, we're going to provide better health outcomes to our patients. They're going to have their care delivered more efficiently, they're going to have less redundancy, and they're going to have better options and choices for the healthcare. And the final point I want to make about patients is that, and this is a very important issue, is that patients still retain all rights and controls of their information and data as part of the health information exchange. They're not giving up any of those abilities to control access to their data. Patients will have the option to opt out of having their data and information shared. And the health information exchange, Connie, has the capability to honor those wishes for patients. I do think and I do hope that patients will entrust us with their information, their data. But again, if a patient chooses not to, they always have that right to do that. I'll ask for the next slide, please. I'll spend a little time talking about the benefits to providers. This is kind of what we speak about a lot when we think about health information exchange. And for those of us who practice on a regular basis, I think many of these benefits are obvious, but I just really want to go over some of them in detail. And Dr. Davis really highlighted that worst case scenario, the new patient on a Monday morning with no records and no prior history, and you're trying to help that patient with whatever issue they came to the office that day. So the first thing I want to highlight here is that, despite millions and millions of dollars and untold hours of time and effort spent on electronic health records, we still don't have a single source of truth for health information. And anybody who delivers healthcare is forced to navigate a myriad of different sources to try to get accurate information for patients. It might be your own personal EHR, it might be the hospital record, it might be things from a lab, it might be a stack of papers that a patient brings into the office that they've collated themselves, and never mind trying to actually track down a current med list for a patient when prescriptions were filled across 3 pharmacies. So for the providers, what the Health Information Exchange promises is that single source of truth, a place where you can go one-stop shopping to try to answer as many questions as possible for your patients. And when you think about Dr. Davis's patient, imagine how valuable that would be on that Monday morning if you were able to log into Connie and answer so many of those questions with really a single source of information for your patients. And you think about where those sources of data come from. And there's so many areas where we're forced to collate data manually or in a way that's inefficient, whether it's hospital records, radiology, labs, pathology, other providers. It's a challenge to do that. And Connie gives us the opportunity to actually bring that together in a single place. Something as simple as even identifying who a patient's providers are. Often patients don't know all their providers. We don't have information who they've seen. Who was the gastroenterologist they saw 6 years ago for their colonoscopy when a patient comes in with a new gastrointestinal issue? Who was the surgeon who did their surgery when you need to try and get records of it? Just being able to collate a list of who their providers are is critically important. And think about this on the hospital side. When a patient is admitted to the hospital, this may be the first time they've been in that hospital. The ability to track down who their PCP is, who the surgeon is, who their specialist is, how much that will improve the efficiency and the quality of the care that they're given. Thinking about how, talking a little more about inpatient services, how much easier it'll be to facilitate discharges and transfers out of the hospital when we have these kind of records. How often does a patient come to the hospital and their discharge is delayed because we're missing a key piece of information, or we're missing information about where they've been treated for a condition before, or we don't understand what their entire medication history is, and how many patients might even have a whole hospital admission that could be avoided if we have access to better information about what testing has been done before, and where we can arrange for patients to have better outpatient follow-up and better long-term care of their issue rather than have it done in a hospital. And think about the benefits both to our patients and our providers and the system if we can even do something as simple as shorten hospital length of stay, reduce admissions, reduce visits into the hospital or nursing homes that were unnecessary. A lot of this, the other side of this is we still have to do a lot of this collation, a lot of this sorting anyway, but it just takes so much more time, right? So instead of, we still have to track this information and this data down, but we're making calls to multiple places, we're making outreaches to multiple places. Think of the staff time that is spent doing this kind of mundane activity instead of actually providing some direct benefit to our patients. So think about how much time we'll save, and think about how much more efficient our encounters with patients will be. And when you think about kind of our satisfaction for those encounters, one of the things I think about is what I really enjoy is being able to be with my patients, to engage them with all the information so I can really provide a visit of value to them. And I think we're all going to have more valuable visits, more satisfactory visits, because instead of worrying about the details and tracking down information, we'll actually be providing real value to our patients and having really engaging and productive visits with them. And the final thing I'll leave the group here with, and anybody who practices regularly, is just think about something as that we really struggle with as much as medication reconciliation, how much easier and how much more productive that will be when we have the health information exchange, collecting data across all different sources to provide us with a much more valuable list. If I could have the next slide. I want to talk a little bit about some of our managed care organizations and insurance companies and the benefits that they would reap from this as well, because the benefits of an HIE really goes across the entire healthcare continuum, and any organization that's involved and responsible for delivering care and overseeing care is going to drive benefits here. And when I think about some of the benefits that I see for our insurers and our payers and our managed care organizations, and some of the goals that they have in improving quality and reducing cost, think about the opportunity to avoid duplicative testing. How many tests are repeated because a provider does not know that a patient's had that test done previously? And think about the opportunities to actually improve efficiency when a clinician can actually see in one single source a broad view of all the testing that's been done for that patient over the last several weeks or months or years. Think about the benefits for patient safety that flow from that as well. If you have an accurate medication list, think about how much easier it'll be to avoid poor outcomes due to medication interactions. Think about how easier it'll be to avoid duplicating tests that might expose the patients to harm or increased risk that they would not otherwise have needed. When I think about the quality work that we do with our payer partners, and we all work quite diligently to make sure that we're all delivering high quality care and trying to improve that care, the Health Information Exchange gives us a great opportunity to actually start to bring together different data sources, not just claims data that may be used to a great extent, but combining that with clinical data and really giving us a much more holistic and complete view of the quality care that's delivered to our patients as they navigate across the delivery spectrum. It really gives us a chance, I think, to move away from some of the quality measures and some of the quality programs that we've been using that have not been satisfactory, I think, to a lot of us who work and live in this space. And it's an exciting opportunity to bring those, I think, to a level that are going to be much more impactful on our patients and their outcomes. Next slide, please. If you think about the functionality of a health information exchange collecting all this data in a single source, it's very easy to see what some of the benefits might be in the public health realm. We have, after living through the last year and the COVID-19 pandemic, we can already start to see the value in having a single repository of information to help us drive quality and to improve care. And things as straightforward as having a robust vaccine registries for all scopes of vaccines across the delivery system in a single source in a single place. And I will, again, I've mentioned my own personal experience, how many times have we been tracking down patients' vaccine history, whether it's an adult or a pediatric patient, to really try to understand which vaccines they've had and which vaccines need to be done. We think about tracking really important public health outcomes, tracking things that are going to really improve the health of the population. This gives us an opportunity to do that we really don't have at this point, to really in a comprehensive way to look at the patient's clinical and claims data across a large spectrum of the healthcare delivery system. And finally, to think about trying to move to tracking outcomes better for our populations. And how do we look at the healthcare that's delivered to our populations? Is it done in a way that really is improving the outcomes that are important to our patients, our stakeholders, and our policymakers? And this gives us an opportunity to use data that's readily available and accessible to drive those decisions on the things that we focus upon, and also to actually show that we're actually making strides and improvement in those outcomes over time. This really is a wonderful opportunity for us to really bring our public health services and resources into a much more direct interaction with our clinicians, our providers, and our patients to help drive the outcomes that we all think collectively are important for our populations. And I'll ask for the next slide, please. And I'm just going to close with one kind of case study that I'm just going to walk through again some of the benefits. And I talked a little bit before about the patient who is encountering a visit to the hospital. And I'm going to highlight one specific function here of the Health Information Exchange. And this is an encounter notification that we'll have available when patients are admitted, transferred, or discharged to a hospital facility. And let's think about what the current state is, depending on your actual level of capability. But we get notified about hospital admissions or discharges in a myriad of different ways. If we're fortunate, we have a direct connection to maybe the local hospital we work with, that we get notified. But if that patient is admitted to a different facility, that notification may be a fax, it may be a phone call. We may not be notified at all. Think about the value, though, of one of the functionalities that will be built into HIE of being notified of admission at the time it happens, that notification being electronic and being immediate, and being notified not only when the patient is admitted to the hospital, but when the patient might be transferred to a skilled nursing facility, and then again when that patient is ultimately discharged out to the community and then back to your office for further care. And not only will you have the capability of being notified about those particular points across their admissions and discharge, but you'll also have access to information that's going to help you take care of that patient when they come back to their office. And whether that's the hospital records, the imaging studies that are important to guide their outpatient follow-up, lab studies, medications, and things that we've talked about. And I think that's just one example of a very difficult patient encounter that's often limited by lack of information, that not only are we going to improve your ability to take care of that patient when you see them, but we're going to be prepping you ahead of time, because you're now going to know when that patient is admitted and brought into the hospital as soon as it happens, and also when they're discharged and where they go after their discharge from the hospital. So I hope I was able to give you kind of an overview of, I think, some of the benefits that the health information health information exchange is going to bring. I want to strongly encourage all of you to really begin the process to connect your organization and your practice to Connie, which you're going to hear about in the near future. And I'm going to pass the baton back to Dr. Greston, and I'm going to thank you for your time.
Thank you, Joe. And let's go ahead and get a little bit of the history of Connie. So Connie is actually the third, fourth, or fifth attempt at a statewide health information exchange in Connecticut. And some of us have been participating in this process for a number of years. But the actual process of getting this health information exchange up and going started in 2016 with a very broad analysis of the stakeholders and a lot of questions and a lot of interviews that were done in order to try to ensure that this time around we met the needs that people really had. And so one of the other things that then happened after that is the group that Joe is on, the Health Information Technology Advisory Council, spent a number of months bringing in that group plus a number of outside individuals, actually creating approximately 30 use cases for Connie. And out of those 30, there were a number that were prioritized to go first. And in fact, they are the ones that are being worked on to deploy. It took a couple of years more to actually get Connie organized into its nonprofit status, but it was felt to be very important to have it be an organization that was a nonprofit, one that was a kind of trusted organization, and it was incorporated in the middle of 2019. And as of 2020, we now have organizations that have gone through initial onboarding and have actually signed on, not just contractually to exchange data, but have actually started to exchange certain kinds of data already. And now we're in the process of taking the next steps. If you go to the next slide for me, a little bit of why this is still needed in our world. There are, as we, kind of saw earlier, about 25% of our participants actually said they are exchanging healthcare data now, and they're exchanging it oftentimes through Epic in their healthcare organization through a platform called Care Everywhere, which is a very effective way of exchanging data. But as you'll notice on the left-hand side there are many organizations, some of them very large, like ProHealth, that take care of, approximately 10% of our primary care patients in the state, perhaps a little bit more. There are community health centers, and there are clinics that are behavioral health clinics that all are not connected either to each other or to the organizations that actually have access to some health information exchange now. And this is a really important thing to realize. There are some health information exchange activities that occur between Connecticut and national levels already. And there's also through the Connecticut State Medical Society, CT Health Link, which is connecting certain organizations to each other through another vendor. So there's activity occurring, but it's not sufficient to actually take care of the patients in the way we need. If you go to the next slide. So as Connie goes live, there are going to be 3 different methods to actually get access to the data. And it's going to depend on several different things. the first thing it's going to depend on is whether you're part of an organization that actually has already has an electronic health record that permits you to kind of sign on automatically. And that will be called you'll be able to launch a portal from directly within your electronic health record. And it'll be single sign-on, meaning that you won't have to re-sign on to the portal. It'll already know who you are as the clinician trying to access the data. So it'll only allow you to get access if you have authorization to do so. And it will know the patient that you're trying to access based on the patient that's open in your electronic health record. Then there is the ability to launch a separate portal directly from the electronic health record, and a number of electronic health records will permit that with this particular product. And for those individuals who don't have either those types of electronic health records, there will be a web portal that you can enter into directly. And actually, anyone that has access through these other methods can also get access through the web portal as long as they're authorized to do so. I'm going to show you a few screenshots of what that will look like and how that might feel. So although this is a tiny bit blurry, this is what it would look like inside the Epic electronic health record. Those folks that are familiar with Epic know that on the left-hand side is information about the patient, and that you would be able to kind of essentially push a button, and then on the right-hand side, you would be able to see information that was in the health information exchange. And we'll go into more detail about what kinds of information is in there and how it appears. But that's essentially what can happen. And you can expand this to be a much larger portion of your screen if you're looking for data. If you go to the next slide, a different EHR, Cerner EHR, which some of our practitioners have in the western part of the state, actually opens up that same in-context portal much larger. And it just occupies a different portion of the screen. But you can see that it's essentially the same thing. Those who are entering through a portal, we don't have a screenshot of how the portal will look right now. But essentially, once you log in through that sort of web page type portal, you'll see the same kind of thing that you will see on the when we do the demos in just a few moments. So if you go to the next slide, I believe we are going to actually show a demo now of what that looks like.
After receiving notification that Delia Detz was admitted to the hospital over the weekend through his ADT feed, Dr. Caranta logs into the Connie portal and is able to verify that he's in fact in Delia's chart and verifies her demographic data. And then he is able to find her discharge summary from the hospital. He verifies her admission and discharge dates, and then finds her discharge diagnoses, which include new onset atrial fibrillation and her known chronic ischemic heart disease. He reads through the reason she got admitted to the hospital, he's able to quickly scan some of the laboratory data that was done during the hospital stay, noting that her kidney function did not get any worse. Follows up on her plan for the atrial fibrillation post-discharge, all of which is very helpful for him as he prepares to see Delia as his next patient. While in the office, she says that she had some additional lab tests done and an echocardiogram, which were done outside of the hospital stay. He's able to review that and notes that she has an elevated sugar. And that she also had a hemoglobin A1C she reviews and does not show active diabetes at this time. Be able to reassure this patient during the visit. Finally, he wants to know what her ejection fraction is and is able to go up to the search feature, type in a few letters, and find the echocardiogram. If there are a large number of documents, this would be helpful in that you could use word from within a clinical document to actually find a document that contains them. As he reviews her echo, he notes that she is normal ejection fraction and reassures her that her heart damage has been minimal from the new onset AFib. After he finishes with his office visit, his note will also be added to the HIE, and when the patient goes to see the cardiologist afterwards, they will be able to find his assessment and plan as well. In essence, this HIE has helped save him significant time as he searches for information about Delia.
So while we get ready to transfer over to the actual presentation by Jen Searles, you'll notice that there's another poll open, which some of you have started to answer, essentially asking, what's the most important benefit or the biggest benefit for an effective HIE? So if you'd like to, we'd love to have you answer that, because we'd like to hear your thoughts and think about, how we can best help kind of moving forward. So while you're answering that poll, I'll let you do that, and we'll give the answers to that poll at the end. And I'm going to shift over now to let Jen talk about Connie.
Thank you, Tom. Thank you, everyone. I am excited to be here and excited to be embarking on this journey with Connecticut. I have been, just a little bit of background on me, I have been in healthcare IT in this state for about 15 years, first with Med 3000 and Pri-Med Physicians down in the southern part of the state, and then with ProHealth Physicians, and then finally at Soho Health before I came to Connie. So I have been through one of those or two of those prior attempts, and I'm looking forward to pulling Connie up and off the ground this time. We're excited about this. Next slide, please. So Vicki mentioned this a little bit in her presentation, and I wanted to reiterate it because I think it's important. When Connie was set up by the legislature through this state statute, we were really set up to be independent, not-for-profit, neutral, and trusted. And it's important for a number of reasons for me to spend a little bit of time talking about that with all of you. Obviously, being independent is critical for us. We are not a state agency. We have administrative oversight by the Office of Health Strategy, but we are overseen by an independent board of directors, and I think that's important for everyone to be aware of. We are not-for-profit. Neutral and trusted really means that as a neutral entity, we are not set up to benefit any one part of the health system ecosphere over another. I'm not here for the benefit of providers over state agencies, or state agencies over insurance plans, or insurance companies over hospitals and health systems. We're really meant to be that neutral broker of clinical data exchange in the state. And then trusted, meaning that everyone participating in our organization has an opportunity to have a voice within our organization. So we've mentioned the Independent Board of Governors, where we have a patient advocate, we have board members representing physicians, practicing physicians, hospital systems, insurance companies, and state agencies. We were also developed with the idea that we would be a network of networks model, and I will go into that into the next slide, but it is an important concept for Connie. We wanted to make sure that as we were, sorry, Ryan, you can move on to the next slide. We wanted to make sure that as we were developing Connie, we were leveraging existing networks that were already in place and being able to ensure that we could be as nimble and as flexible as possible by leveraging those various exchanges. So for example, Tom referenced CT HealthLink and their HIE. We also want to make sure that we can connect to national exchanges like Care Equality and eHealth Exchange to be efficient. Next slide, please. So we've talked a little bit about why we need Connie. Tom has given you a little bit on how a provider can use Connie. I wanted to give you a sense of the timeline that we have in place for Connie deployment for fiscal year 21. We are anticipating that by Monday, May 3rd, Connie will be announced to be open for business or commencing operations. That's our official launch date. And as you heard from Vicki Veltri in her presentation, that really starts the clock ticking on our mandate to have folks connected into the HIE. So we anticipate that that will be Monday, May 3rd, this upcoming Monday. Tom talked a little bit about some of the ways one can access the Connie app and the data within Connie. We referenced the app. That app is configured and ready for those organizations who are able to deploy the Connie app. We anticipate the portal being ready later at the end of the spring, early summer. That will be available for folks to participate in Connie that way. We anticipate that when our website goes live this evening, that the consent form will be available on there, our e-consent form, and I'll go into that in a little bit. And then as well, we anticipate a provider-mediated consent form later in the summer. Finally, at the bottom, you'll see some of the data we anticipate and are already consuming in Connie. So that's those ADT messages, those admit, discharges, and transfers. Impanelment, which is really a key set of data that I'll go over later on, but that's really about establishing the care relationship so that we know which patient is affiliated with which organization and provider. And then you'll see other what are called HL7V2 data feeds for labs, radiology, clinical notes, and CCDAs, as well as we anticipate later this summer being able to connect up to the state's PDMP and being able to display that data within Connie. Next slide, please. So as we talked about, commencing operations is important for a number of reasons. One of those is that per the state statute, once we have commenced operations, all hospitals and labs have 1 year to begin connecting with Connie, and all other healthcare providers have 2 years to begin connecting with Connie. So that date of May 1st of 2021 is important. Connecting with Connie really means that you are sharing your patient's clinical and demographic data with Connie. Next slide. So let's talk a little bit about services and critical data for Connie at its start. I think it was Dr. Caranta talked a little bit about the Encounter Alert service. We'll go to that one first. And that's really a service that we have live already. This is a legacy service we got through the Department of Social Services that enables providers to receive an alert when their patients are discharged from an acute care hospital. In order to make all of the use cases work generally within Connie, we're going to need one key piece of data, which is your impanelment data. And your impanelment data is important for a number of reasons. Number one, it sets up the care teams. It enables us to understand which patients belong with which organizations. And that's important so that we are routing information to the right providers, but it's also important from a privacy and security perspective to make sure that we're sending the data to the right individuals who should have access to it. And clinical data is critical clinical data that we need to really feed Connie. And this is data, as I talked about before, ADTs, labs, transcribed documents, and CCDAs, as well as access to the PDMP. So all of these are use cases and critical data that we have, that we are either ingesting now in Connie or are able to ingest now within Connie. Next slide. So as we continue with signing up organizations into Connie, you can see some of the types of data that we think are critical to be able to ingest into Connie and be able to present to providers and organizations at the point of care and during care coordination or transitions of care. I think both Dr. Davis and Dr. Caranta eloquently spoke about all manner of data that is critical and important for them as they're seeing patients and being able to pull that data together within Connie and display it for providers and care teams and organizations that are trying to manage patients. Next slide, please. But that's not all there will be within Connie. So I think Tom alluded to some of the work of HITECH and the use cases that they had proposed for us to take a look at. And we have a list of, I think, 12 to 15 different use cases that have been vetted through the Health IT Advisory Council. These are some of the ones that we have put on the list that we know are upcoming. I mentioned getting access to the PDMP, or the Prescription Monitoring and Reporting Service. The HITECH has completed and accepted a report on best possible medication history, so that is being sent to Connie for review. Advanced directives, e-consults and e-referrals, as well as e-consent, or a provider-mediated affirmative consent, are all use cases that we're looking at for future development within Connie. Next slide. Dr. Karanta touched on this, and I want to make sure that we spend a little bit of time on this because it's important for me to make sure that I let people know that though I believe in secure data exchange for the benefit of patients, I understand that not everyone is comfortable with that. So when Connie launches its website tonight, patients, consumers today whose providers may not even be participating with the HIE right now will have the opportunity to opt out of Connie. They will have a plethora of ways to do it, but you can go on our website, you can fill in the web form. That web form will come to our help desk team, who will notify you that they've received your form, and in 5 days, that notification and that decision will be maintained at Connie. And what that means is then if we ever get data from a provider into Connie, we check that opt-out or consent portal, make sure that if your name is in there, then your data does not come into Connie. So we make sure that we do that. All patients will have that ability to opt out at any time from participating in Connie. They can also opt back in. There will be methods and mechanisms. They can call our help desk. They can go online. There will be ways for patients to opt back in. But I think it's important that we make sure that patients have a way of having their consent to have data exchanged through the HIE honored in this way. Okay, so next slide. So you might be wondering if there is perhaps some help to get you connected to Connie, and there is. At the moment, if you can go to the next slide, there is no cost to connect to or receive data from Connie. We are fortunate at this time to be able to have funding through the federal government for a limited time to be able to offer technical assistance dollars for healthcare entities who want to connect to Connie. Unfortunately, those dollars do expire at the end of September, so we are working furiously to try to get as many organizations connected as we can to take advantage of those technical assistance dollars. But there are dollars available for those organizations that want to connect now to Connie. And so hopefully by now you are eagerly anticipating, how do I get connected to Connie, Jen? So if you'll go on to the next couple of slides, please, Ryan. We have a team standing by to help practices and providers get connected to Connie. So there's basically sort of two main steps. A legal onboarding, there's always the legal part, right? Where we ask organizations to sign a trust framework. And this is really common rules of the road for how we're going to share and use data, what you're supposed to do with it, what you're not supposed to do with it, how you secure it, and how you use it wisely. You sign on to at least 2 use cases, and as long as there are technical assistance dollars available, you can receive technical assistance dollars to help with that connection. And then the technical onboarding is really all about contributing data and consuming data. So there's 2 steps in that, and we anticipate that we can get folks connected, up and running in short order once they have signed on to the legal framework and are able to sign on to use cases. So you will hear more information at the end of our presentation on how you can get connected, and as always, there will be our website as well. Next slide, please, Ryan. So who are some of the organizations that are currently connected to Connie? I'm excited to announce that this slide is actually out of date already. We have at least 1 more practice under the medical practices and a few more within CT HealthLink. So the organizations that you see on this screen have all legally onboarded. They've signed that data sharing framework. They've agreed to that trust framework for connecting to Connie. You'll see 2 of the largest health systems in the state, Yale, New Haven, and Hartford, as well as 2 of the largest IPAs or clinically integrated networks in the state, Soho Health and CMG. 2 of the 3 administrative service organizations for Medicaid, the Community Health Center Association of Connecticut and Signify Health. And then I'm excited that we have, back to that network of networks model, we partner with CT HealthLink, and through connecting to CT HealthLink, they are in the process of onboarding the pediatric practices affiliated with the Children's Hospital Community Care Network. So we're excited to see the growth of that hub, if you will, as it connects into Connie and provides for that data exchange, as well as ProHealth Physicians, one of the largest primary care physicians practices in the state. We are kicking off our technical onboarding and hope to have data flowing from them later this summer. All of the organizations that you see in the upper right-hand corner are all part of our Project Notify service. They are receiving encounter notification services from Yale and Hartford when their patients are discharged from those facilities, so that they can do the appropriate follow-up care, get their patients in for appointments, make sure their meds, that they understand their discharge instructions and the like. So I hope in short order to have 3 or 4 screens and not be able to fit this on one screen anymore. But we are definitely moving along and getting folks connected into Connie. And with that, I believe I'm turning it back over to you, Tom.
If we go to the next slide, we're actually going to see now if we can't help our good Dr. Davis and see if we can't get his information to him on that Monday morning practice and help to Monday morning patient, and see if we can't help him in that process. So hopefully now when he logs in a few weeks, when he's able to access that through his ProHealth site, he'll be able to see the following. So if we go to the next slide.
Now get back to that Monday morning patient that Dr. Davis needs to see, but he has never had in his office before. Since Jenna was already registered with him, he was able to launch this directly from within his electronic health record. One of the features of the HIE portal is that you're able to search based on type of information. So here, Dr. Davis picks clinical notes first and is able to then review a transfer and discharge summary for the patient. If there were notes from a clinical practice that the patient had been at beforehand, he would also be able to find that information in this section. Next, he searches for radiology information. Finding none, he is then able to search on laboratory information. And notice is the most recent metabolic panel is given that the patient also has a history of renal failure, he is able to look at the microscopic urine and find that to be normal as well. Another useful search feature for the Connie in Context app is that you can filter by a variety of different information, including the dates when you are looking for data, so that he is able to look for the last 2 years worth of data on this patient to get up to speed, as well as the ability to look at the various sources of the data. In this example, there's only data from the Haven Health System, but if there were other organizations that had provided data, he would be able to pick and choose which ones he wanted to see. We are providing you with just some of the examples of how to interact with the Connie in Context and portal applications.
Now we're going to go ahead and pass it back over again to Dr. Davis, who's going to talk with us a little bit about one of the other roles that Connie can play.
Thank you, Tom. In addition to my role as a full-time practicing internist, I am also currently serving as a regional medical director for ProHealth. I oversee 14 separate practices. In my practice, my job is to take care of the patients in my practice. As the regional medical director, my role is also to make sure the practices in my group are also able to adequately take care of their patients and thus the populations of patients. So there are various quality metrics that we need to be responsible for. Most insurance companies are compensating their medical groups on how well the medical groups are caring for their patients. Some of those criteria involve, if you're a diabetic, have you had a hemoglobin A1C this year? How well has the diabetes been under control? Have you had a dilated retinal exam if you're a diabetic? Have you had a urine microalbumin test? Are you up to date with your pneumonia vaccines? Are you up to date with your colorectal cancer screening? I like to say that the majority of the metrics take care of themselves if you practice quality medicine. Unfortunately, a lot of this testing is done outside of our organizations with unaffiliated physicians, and we do not always get the results in a timely fashion. We cannot make the best decisions regarding the care of our patients or populations if we do not have their data. Next slide, please. A lot of time is spent looking for required testing, as stated before, such as mammograms and the dilated retinal exams, if the gynecologists and the ophthalmologists do not forward those tests to us. We also have to close gaps in care where lab data is missing. Again, this is the diabetes testing, the microalbumin levels, and many other testings. It is far easier for our staff to log into the Health Information Exchange and obtain the above testing than to reach out to the patient or try to find the facility the testing was done at to try to get the results. Having the data will enable us to have a more focused outreach program for our diabetics, heart failure patients, and the other high-risk populations. And now we'll show you a demo on using Connie for the population health.
As Regional Director for ProHealth Physicians, Dr. Davis is in charge of population health for Northwestern Connecticut. He has a team of care coordinators who help him find patients who are due for certain screening procedures. Here we have an example of him evaluating the mammography results, and his care coordinators are able to see that the results are quite good, except there are some patients who are still missing mammogram information. When they look at who has missing data, they're able to see Connie, new patient, find her date of birth and her medical record number, and are then able to log into the Connie portal, where they're able to see that by searching for mammogram, that Connie has a mammogram result that is recent. They're able to open that up, see the results of that mammogram, which validates that it has been done, and the patient does need some follow-up. They're then able to return to their quality improvement data set and mark that the patient had this procedure done at another facility that they did not have access to from their electronic health record. Just as they can do this for mammograms, they are also able to do this for diabetic retinopathy scans for the eyes, as well as for colonoscopies and other outside of the office procedures. This way, the HIE can help with managing a population of patients. As Regional Director,
Now we're going to go back and have Jen share with us a little bit about how to make this work effectively.
Well, one of the one of the legacies of Michael Matthews, who was the interim director before me, is he introduced me to this concept of Metcalfe's law. And I like to use it here for the HIE because I think it's apt. Metcalfe's law is really a telecommunications principle, and I know nothing about telecommunications. However, Metcalfe's law basically states that the value of a network is proportional to the square of the number of connected users of the system. And basically, I think that can be translated to HIEs as well, right? The more providers and the more provider organizations you have, the more data that you have flowing, the more valuable this is to all of the organizations within it. And so my push, my plea, my ask for all of you, if you can go to the next slide, please, Ryan, is to connect with Connie. Connie is open for data sharing. As we told you on Monday, we anticipate the announcement will be made that Connie has commenced operations. And I look forward to having all of you as participants of Connie and sharing your data with Connie for the benefit of the patients in the state of Connecticut and to empower providers and healthcare organizations in more timely, efficient, secure, accountable, and transparent clinical data exchange. Thank you.
Thank you. I think now we're going to go to questions. If you go, I think you passed the slide on questions and whatnot. So I see that there are a number of questions in the chat. I'm going to ask that people actually try and put them in the question and answer area, just because it's a little bit easier for us as panelists to read. But there are a couple of different themes from those questions. And what I'm going to try to do is kind of link those themes together and ask our panelists to address them. And some of the questions may be specific for one panelist. Some of them may actually be important to kind of talk about by several of them. So one of the simplest questions was, will Epic connect with Yale New Haven Health? And I think, Jen, you already answered that one. And Yale New Haven Health is actually probably on the very early track to be exchanging data with Connie.
Yes.
And so the other questions really relate to as you actually get involved in utilizing Connie from a particular organization. You know, the question arose, you know, will there be a tip sheet as to how to look at data from particularly Epic? I would venture to say that each of the organizations is going to have its own way of kind of communicating that. And as the onboarding process occurs, you know, that'll be part of the process to work through. I'm going to stop my statement here and just ask Jen to talk a little bit about what the onboarding does and how it helps with that process a little bit more.
With the process of, oops, I'm sorry. With the process of getting connected?
Or educating folks about stuff, like in a particular organization, how to use it.
Yeah, so I think that will largely, we will partner with you can all hear me, right? We will all partner with the participating organization to be able to work within their training, their staff processes for that. But yes, there will be webinars on our site. There will be videos on our site for how to connect. Most of the connectivity and most of the portal is fairly self-explanatory, but we will have tip sheets, we will have videos, we will have staff that will be able to help. And in those organizations, those larger organizations where I anticipate they've got a fairly well-oiled machine for how they get folks onboarded and trained, we will participate with those organizations and that staff.
Thank you, Jen. There are a couple of different questions that relate to sharing of image information. So image reports, for example, radiology reports. And then actually some comments and questions about will Connie actually be able to share radiology images in the future. So Jen, I think this is again a question for you, but I think also the other panelists can weigh in as to the potential value and how they might see that working as well.
Thank you. Yes, that is a great question. I see a question from Dr. K with that as well. I do know the reports will be available, and I'm going to put a pin in this and make sure that I can come back and answer the question about images. I don't have the answer to that right now, but definitely reports will be available as we get those data feeds into Connie. So let me have that as a follow-up.
Yeah, and with our other panelists, maybe Joe, would you like to speak to what you'd love to see and what you'd love to experience from that image perspective?
It's a great question, Tom, and I think it'd be a really tremendous value add if we could do it. I'll give you the scenario. You know, I see a patient in my office and I order a CAT scan, and then they have to be referred to the hospital for admission for the results of that scan. If that scan is done in a different facility, think how great it would be for those actual, not just the report, but the images that the surgeon or the physician and the hospital would actually need to review could be available in real time. Or you know, the opposite, someone who has a CAT scan in the hospital and then is discharged to see their specialist, and then how valuable it would be for them to see those real scans. So I think progressing to the point where not just transmitting the actual report, but somehow the scans themselves would be a huge value add.
If I can add on to that, this is a big boom to the radiologists and would definitely help the patients as well. If a radiologist is doing a CAT scan on a patient, they have no background on the patient, they see a nodule or a lump or a mass, they would then be able to look and see, does this patient have any other similar tests done anywhere throughout the state? Any of the imaging providers that are affiliated with Connie, and they can see the actual images and make sure, oh yes, this nodule was there 3 years ago, it's the same size, nothing to be concerned about.
Excellent point. That's great to kind of think of it from that perspective as well. There is a question a little bit about how organizations that have, say Epic and are utilizing Care Everywhere, how they will actually be able to both connect with Connie and whether their organizations will actually share data back out automatically or whether it will have to get pushed. So a little bit about how it functions, Jen, might be what really is the question, is how does Connie function in terms of the actual data exchange? And this may be a little bit more technical than the average individual wants to know, but it's a good idea that we share some of that information.
So just, I want to make sure I understand the question. For those folks that are on Care Everywhere already, will they be able to access Connie and have access to the data that's in Connie as well?
I think that's part of the question. So
Yeah.
that's one.
Yep. So the answer there is yes.
And the second would be, how would they be able to share data outside of Care Everywhere to other organizations? To let's just say to Joe, or, you know, if you're at Yale, how would you share to Joe?
Yep. So that would be an interface from Yale into Connie with the appropriate data. So, and that can be an ADT, that can be a CCD, that can be your ORU, which I mean broadly to mean results. So once that data is in Connie and available within Connie, then Alan, Dr. Davis will have access to that data. And again, the 3 ways that we mentioned would be sort of using the portal and being able to log in there, maybe single sign-on from his Allscripts EMR. And then for those organizations that will have access to the embedded app, they will be able to use the embedded app.
Excellent. And thank you for that. I'm going to kind of try to group the next comments a little bit together. There were several comments and questions about patient access to data through Connie, and whether that was anticipated, and a little bit about, you know, when and how that might occur.
So there's a lot there. So the mandate that set up Connie did anticipate that at some point we would be able to provide patients access to the data and information that's in Connie. We are working towards that. What we will have at the start of Connie, as I mentioned at the beginning, is patients will be able to opt out of data sharing through Connie. And I want to be somewhat clear about this. Opting out of data sharing through Connie does not mean that physicians cannot share data. You know, as the physicians on the call know today, patients' data get shared through faxes, through direct messaging, secure texting, through thumb drives, printing and mail in certain circumstances. So there's a myriad of ways that data gets exchanged. Our hope and our goal with Connie is that by providing that secure data exchange, we are able to make that much more efficient on both parties. But if a patient does not want to participate in Connie and opt out, then the providers can still exchange data for taking care of patients, but they will be able to opt out. We anticipate through the 21st Century Cures Act, and I think there was another question about that, being able to find a way to provide patients access to the data that's within Connie. We're working with our vendor on a number of ways that we might be able to do that, and I would anticipate that later this summer into the fall, we'll be able to go public with what that will look like. And then the third area that I wanted to mention as well is that we do have an accounting of disclosures. So for example, if a patient calls and says, I'd like to understand who's looked at my data in Connie, we will be able to provide that information for them so they're aware of who's been looking at their data. Did I get all the parts there?
I think that was quite good, kind of answering that. Maybe Dr. Davis or Director, maybe start with Dr. Davis to have his perspective on patients being able to view and look at data in Connie. But the other question that was also raised is not just the question of whether they can view it, but whether they'll be able to kind of make errors or entries or corrections if there is corrections to be made. And that's a common, I'll have Dr. Davis answer first, and then maybe what his thoughts are on that, and then maybe you can follow up.
Well, for as long back as I can remember, the patient's chart does not belong to me. The patient's chart also belongs to the patient way back to the 8 to 10 inch paper chart days. The patient can call or send a letter and request notes, and they would be copied off and mailed to the patients. With the CARES Act, the patient can request electronic access to their chart. As of right now, that I think is being implemented through our individual EHR's patient portals. But I'm going to defer to Jen how Connie can facilitate patients being able to log in and not only see their notes, but see their labs as well.
So as I said, hopefully by the end of the summer, beginning of the fall, we'll be able to share with everyone our plans for providing patient access and to seeing their data. It's obviously has a lot of concerns, and we need to make sure that we can validate patients and make sure that they're only seeing their own data, so that it's going to be critical that we do this right. In terms of, there was a question about fixing data that's in Connie. Connie, what we would do is refer you back to the organization that provided us the information, and that would have to be fixed within those medical records. Connie is not going to have the capability for doing any sort of fixing of those records within the application.
Excellent. And I am trying to look for the next theme of questions here. There is a question about pharmacies connecting, and actually maybe talk a little bit more, Jen, about other than healthcare organizations, the pharmacies, the payers, other things like that. Give some updates on what's happening with that.
In terms of connections? So we continue to have, I think the network of network slide that we referenced at the beginning, we continue to have conversations, and we anticipate that we will be working with a number of different organizations within the healthcare ecosystem to be connected to Connie. Because of the mandate, our focus has really been on making sure that we get our hospitals and health systems connected, and then our labs, and then we'll be turning our attention as well to our provider practices. So they're all sort of in the queue for conversations and lined up, but my main goal is to make sure that I can assist hospitals and health systems with getting connected so that they can meet the mandate before the time runs out.
From a clinician's perspective, this should not be difficult, but it is the hardest thing with seeing patients, is making sure the medication lists remain accurate and up to date. When we get notes from specialists at different hospitals or outside organizations, it is surprising how often there are discrepancies between their medication lists and mine. We try to verify with each patient. It says here, you're on lisinopril. Are you taking 20 milligrams? Yes, no. Oh, I stopped that 6 months ago. Hopefully with getting pharmacy informations, we'll have access to the last fill. And also we can ensure medication compliance. And this is one of those insurance company quality metrics that are going to be looked at in the future. Because the last thing we want to do is prescribe a duplicate medication or even an interacting medication, especially when the patient does not always know what they are taking.
If I could jump in on that as well, I think
Go ahead, Jen.
Sorry, the work of the MRPC and the high tech, I think, will come in for that, and I'm excited to get that report so that we can look at that best possible medication history. So thank you for that validation.
And for those that don't understand the terminology of MRPC, there are many of us who have live in acronym soup in the HIE world. The MRPC is a group that was set up by the state and under the HIE TAC, which is that advisory council, and it's called the Medication Reconciliation and Polypharmacy Committee, and it's been meeting for several years. It's minutes and its recordings of webinars are all online at the Office of Health Strategy. So there's a lot of information that anyone who'd like to follow up on, we'll actually include a link to it in when we send out the FAQs. I think there is some additional questions regarding like how behavioral health, substance abuse, ID information, and any specialized laws, any limits that might occur there. So maybe you want to tackle that, and then maybe Joe, you can kind of talk a little bit about that from your perspective after Jen answers.
Yeah, so at the start, Connie is not going to be getting any sensitive health information or Part 2 data. We would anticipate, and I shared with you a little bit about a provider-mediated affirmative consent. The policy that the patient consent policy that has been out for public comment from the Office of Health Strategy anticipates that Part 2 data would require affirmative consent before it is shared within Connie, and our policy follows along with that. So we will not be sharing Part 2 data within Connie until we have that process worked out for affirmative consent.
You know, Tom, I would just add that this is a really.
Joe, do you want to share the pros and cons of that from primary care and a large group perspective?
First of all, I'd say, Tom, this is a really important issue, and you know, anytime we're embarking on creating a mechanism to exchange data like this, we have to be mindful that there are different types of health information that deserve particular protections and particular safeguards, and they were just alluded to previously. So as Jen had said, we do need to proceed cautiously and slowly and make sure that patients are giving appropriate consent for that to happen. I think it's worth consideration, though, of some of the value, though, in finding patient-supported ways to share that information. And one of the challenges, and Dr. Davis can probably agree to this, is that in doing population health work, when you don't have access to, for example, some behavioral health information, it's very hard to take care of the entire patient. And we all know how important those issues are in impacting the entire health of our patients. And so I think we have to work together to find the right balance for that, so that we share information in a responsible and a patient-sensitive way, but also do our patients the best service by making sure that the appropriate providers have access to information so they can care best for them and that they can actually make sure that they have the best outcomes. And I think the best approach to this is to have open, honest conversations, have good governance processes in place with strong patient participation, and then have the opportunity for public comment and open discussion about it, which I think we have here. I think we've actually done that across the board. So I think it's a problem that we're going to be able to solve with our patients' best interest in mind.
So those are excellent answers. And by the way, there are lots of questions coming in, and we promise you that any questions that we do not get to, we are going to answer them afterwards in an FAQ. So we'll pull together answers to that. There's a couple of different questions that have the theme of how fast the data will be available once it is done. And an example of an ER patient visiting one emergency room, and then the next day visiting another one. Will there be the ability to see the data that quickly? And then the other question around data availability relates to whether or not you'll be able to kind of actually import some of that data directly into your electronic health record, such as discrete data like the labs that were there, or so how fast will the data be available, and then what will you be able to do with the data from Connie?
Yes. So the data the short answer to that is, as long as we have a feed coming in from, say, a hospital with that ADT feed, as soon as that ADT message gets over to Connie, it will be displayed. I don't want to say instantaneous because nothing is instantaneous, but it is expected to be there as soon as we get the message and we can process it, and it will be up there. So a visit from the day prior, we'd be able to see that for sure. As to how one interacts with the data within Connie, I think there are a number of different ways one can do that. My best understanding, and as I've worked with the team from our technology vendor, the data that resides within Connie can be printed, can be pulled into your own electronic medical record, but it's accessible and available in the portal rather than being all shoved into your electronic record and sort of blending with all of the rest of the data and information within your EHR. So it's available for you to see, it's available for you to look at the data that you want to look at, and then pick and choose the information that you want coming back into your medical record.
So that's a good summary, I would say, of where things stand right now, and where the technology that is underlying this stands at the moment. There was, some question. There was an individual who was previously in Maryland and utilized CRISP and raised the concern that sometimes there were too many matches to a given patient. The date of birth and the last and first name, when they were looking things up, ended up with too many patients that had the same info, too many patients that came up in the search. I do know that is an area where a lot of work has gone on in the last several years around patient matching. So I don't know, Jen, if you have any updates or things you want to share about how patient matching occurs in Connie.
So I don't have any updates necessarily. I think that's good feedback, and I will take that back and make sure that I talk to the team as we do that. But the patient matching algorithm within Connie has been honed and refined and is iterated over and over again. And I've learned a new word recently that's hydrated. So not only do we look at data and we pull it in to do the matching across organizations, but we also hydrate that data and information so that we get a better matching. So I think patient matching, duplicate patients, it was the bane of my existence in some ways at ProHealth when we had an EHR, and sort of trying to make sure that we didn't get duplicate patient records. It's a constant work stream within any organization where you're collating multiple data sets together to get that information pulled. But that's good feedback, and I'll take that back to the team and make sure that we're keeping an eye on that.
Okay, there are some other questions. How many years of data will be included in Connie? Is there going to be historical data, or is it just going to be data going forward? So I think that, is there data from the past? And how long will it stay persistent in Connie once it's there?
Yep. So we are asking, at least for patient panels, to have a 2-year look back so that we can make sure that we've got your patient data in there. And then the data will persist until or unless the organization decides to opt out of participating in Connie and or the patient doesn't want to participate.
And then I think I'm going to kind of take the prerogative to ask one last question before we close down. I believe somewhere in this question list, somebody asked about how Connie is going to be paid for going forward. And that is an awfully good question. And it probably is a great way to sort of end our presentation.
Yeah, so for fiscal year, what are we in? We are in fiscal year 21. For fiscal year 21, Connie is 100% funded through dollars from CMS and DSS and a contract through the Office of Health Strategy. Going into fiscal year 22, we anticipate building a funding model that includes continued work with DSS in terms of services that support Medicaid and Medicaid paying their fair share of the technology for Connie, as well as an insurance fund that we will have accessible as well. We anticipate then going forward being able to draw funds from either fee-for-service revenue, and I don't mean fee-for-service in sort of the insurance payer frame, but fee-for-service where Connie perhaps and the example I always use is perhaps the Department of Public Health would like Connie to manage a lead registry. And so would contract with Connie to be able to build that lead registry, have the data available, the reporting available, the authentication of users. That would be a service that Connie could provide to the Department of Public Health. So we'd anticipate there would be fee-for-service revenues, some subscription revenues, and then continued funding from the federal government.
So that will be our last question, as we are really almost at 7.